Hello, everyone. Hello, dear friends. Today we are going to start our session for the record based questions in ophthalmology, which were asked in the January 2024 exams. So these questions they have been compiled on the basis of what was recalled by the students who attended the exam, and so the language of the question statement or the choices given, the options given may not be is supposed to be not exactly same as it was asked in the exam, but what I have tried is to get it as close to the getting a legitimate question as possible. And let's start our session. um, in ophthalmology, there were like about 18 to 20 questions which were asked, and some of the questions were fairly straightforward, almost like a one liner based upon the clinical feature of a condition. Some of them were based upon like clinical case. There were few image based questions also, and there were one or two questions which were tricky, and since we what exactly examiner wanted to ask we really don't know, so we will assume that what examiner wanted to ask, and we will try to answer that question based upon that. Okay, so let's start our recall session for the ophthalmology questions, and I'm going to begin with the first question. So the first question here in my list is a pretty straightforward question, and I hope all of you who had undertaken the classes, who have gone through the notes, or who did the mock test, this is a very very simple straightforward question. The question was, the shield ulcer is seen in which of the following conditions? And the choices given to us were VKC, that is vernal keratoconjunctivitis, or also known as spring catarrh, trachoma, phyllectanular conjunctivitis, or maybe an autoimmune ulcer. So when we talk about the shield ulcer, n number of the times we have discussed that this is associated with VKC. So a pretty straightforward question in my opinion. The shield ulcer can be a complication of vernal keratoconjunctivitis. A quick refresher about vernal keratoconjunctivitis, which is also known by the name of spring catarrh, as you all know. Now, this is a type 1 hypersensitivity allergic conjunctivitis. Okay, the signs and symptoms are very, very typical of this condition. There will be a young child, mostly a male child, who presents with itching and ropey discharge, which is much more severe or aggravated during the summer season. You will see cobblestone papillae on the palpebral conjunctiva. When these papillae they are present on the limbus, as you see in the image here, then we call them as Horner-Tranta spots. So this is again a very specific sign associated with VKC. And sometimes there can be development of a corneal ulcer as a complication to VKC, which is known as shield ulcer because it kind of looks like a shield. Okay, so this is your shield ulcer, which is a complication of VKC. So all of us, I hope, have marked the right answer for this question in the exam, because this was a pretty straightforward question. Another sign which may be present, especially in the long-standing cases of VKC, is what is known as pseudogerontexon, or also called as Cupid's bow, which is a peripheral corneal opacity like arcus senilis, but it is not a true arcus senilis. So that's why it's called pseudogerontexon. So answer to the question that where you see shield ulcer is vernal keratoconjunctivitis or spring catarrh. Moving on to the second question, again, in my opinion, this was a very straightforward question and often repeated topic, often revised topic. The question was, which is the type of the cataract seen following blunt trauma? Again, a very important and high yield topic as far as your exams are concerned. What kind of changes you see, or what kind of complications can occur in the eye related to blunt trauma. One of that is the cataract developing as a response to the blunt trauma. And the type of the cataract which we see has a very specific morphology. It looks very specific, like a rosette flower. So that is why it is called as rosette cataract. Okay, so many a times we have revised, blunt trauma leads to rosette cataract formation. And as you know, my friends, metabolic cataract is when the cataract develops as a complication to some kind of metabolic disease. For example, the cataract which develops in Wilson's disease will be labeled as metabolic cataract. And it looks like it's given the name sunflower cataract, if you remember. Similarly, a diabetic patient, when they develop cataract, again, that will be a metabolic cataract. And in diabetics, we know we get snowflake cataract. Toxic cataracts, when the cataracts they develop as a result of some kind of drug toxicity. For example, it can be secondary to steroids, or there are other number of the drugs which can cause that. Nuclear cataract can be a type of the congenital cataract, or nuclear sclerosis can be a type of the senile cataract. But what examiner here was asking very clearly, which cataract you see in blunt trauma, and this is what you see in blunt trauma. Please always, connect this image with blunt trauma. So when the lens shows an opacity in the form of a rosette, here what are we seeing? We are seeing there is an opacification of the lens in the form of a rosette. Then it is a rosette cataract, which is a feature of blunt trauma. Okay. And again, I hope that all of you have marked this as the right answer, because this didn't have the scope of confusion as far as examiner was concerned. Right? Rosette cataract seen with blunt trauma. Now, moving to the next question, which in my opinion was relatively a new question asked in the Fmge exam. And here they did ask question related to an important topic, that is your extraocular muscles. But this time they asked about the anatomy related question for the muscles. So the question was something like that: which of the following is the correct sequence of rectus muscle insertion around the limbus? And maybe they also put a terminology of spiral of Tilloch's. Even if that spiral of Tilloch's was not mentioned in the question, the correct sequence of rectus muscle insertion around the limbus, that is what they want to ask you. And we know we have 4 recti muscles, and all these muscles, they insert onto the sclera at different distances from the limbus. And when we hypothetically join those points of insertion, we get what is known as spiral of Tilloch's. Okay, so to answer this question, we should know that this is how the insertion of different recti muscles is there on the sclera around the limbus. So in this figure, if you see, the distances have been mentioned, and based upon this, you can notice that your medial rectus muscle is inserted closest to limbus, that is at 5.5 millimeter. Okay. Then your inferior rectus muscle is inserted at 6.5 millimeter. Your lateral rectus muscle is inserted at 6.9, and your superior rectus muscle is inserted at 7.7. So when we are joining these insertions in an imaginary spiral, that is what is known as spiral of Tilloch's. So to remember this sequence of insertion, we can remember a simple mnemonic, that is MILS. M for medial rectus, I for inferior rectus, L for lateral rectus, and S for superior rectus. Okay, so MILS gives us the correct sequence from closest to farthest muscle insertion from the limbus. Okay, and you can remember this as MIL, mother-in-law, and with respect S. So in plural, you can say S. Mother-in-law S. Mills is the correct sequence. So coming back to the question there. So here my choice D is showing me the correct sequence. Medial rectus, inferior rectus, lateral rectus, superior rectus, MILS. Mills is what is the right answer here. Okay. Question here. Now this was a very good question, I would say, a very nice clinical case based question where they gave you all the key points. Remember when we discuss in the revision test, when we discuss in the mock test discussions, I've always been telling you that look at the key words which are there in the question statement, because they help you to point to the right answer. And that was what was here in this question. So what are they mentioning here? That there is a diabetic person who had cataract surgery done and now presents with decreased vision. So this patient is post cataract surgery. He's a diabetic, okay, and now presenting with a decreased vision. There is seen honeycomb appearance on fundus examination. Honeycomb appearance on fundus examination is your first keyword. And then flower petal appearance on FFA, that is fundus fluorescent angiography. That is your second keyword. So two keywords which are pointing straight to one diagnosis. So decreased vision post cataract surgery. Now this patient is showing honeycomb appearance on fundus examination. Though the patient is diabetic, but they have not mentioned that there are any hemorrhages or there are any cotton wool spots or hard exudates. No diabetic retinopathy related changes have been mentioned. Only honeycomb appearance on fundus examination and flower petal appearance on FFA. So if we know that which condition shows flower petal appearance on FFA, we have our answer ready with us. And that, if you know, my friends, it is your cystoid macular edema, the condition or the disease, cystoid macular edema, which results in flower petal appearance on angiography. So the right answer here is cystoid macular edema. Now, just a refresher here. Now, on fundus examination, because there is fluid, now what has happened in the macular area, in the central area, the fluid spaces are formed in the form of cystoid spaces, which starts in, if you remember, in the layer of Henle's layer, and then they move on to the inner nuclear layers also. So these cystoid spaces, they give honeycomb appearance, which can be seen when we do the fundus examination using 90D lens on the slit lamp. So maybe that honeycomb appearance is not very sharp on this photograph here, but you can see actually these kind of spaces on fundus examination when you do the examination with 90D lens on slit lamp. Then examiner is already making your job easy by giving you another hint that you are getting flower petal appearance on fundus fluorescent angiography. because these cystoid spaces, they accumulate dye. The leakage of the dye is seen in the form of these fluid spaces, as you are seeing here. So this is how the flower petal appearance looks like on FFA in the cases of cystoid macular edema. And if I would like to share the OCT scan of this patient with you, that will look like something like this. So the OCT scan, the optical coherence tomography scan of the macula of a patient who has cystoid macular edema will look something like this. So here you can clearly notice that how these cystic spaces they have formed, which were leading to honeycomb appearance and the flower petal leakage. Okay, so remember these things for future reference also. All these, they point toward the diagnosis of cystoid macular edema, so which was our right answer here. Why cystoid macular edema is the reason, because if you remember, one of the late complications or even the intermediate complication of cataract surgery can be cystoid macular edema. Sometimes because of the inflammation after cataract surgery, a patient can develop cystoid macular edema, which is also given the name of Irwin-Gass syndrome. Irwin-Gass syndrome. So that's again is post-cataract surgery cystoid macular edema. Okay, so this is not a case of posterior capsular opacification, which is the most common complication of cataract surgery, because in that case, your fundus will be normal, your FFA will be normal. This is not diabetic retinopathy because no other change besides these features are seen on fundus. It is not central serous retinopathy because central serous retinopathy has a different kind of OCT appearance, and on FA also we see ink blot or smokestack leakage. If I have to remember what is the FA appearance of central serous retinopathy, I will remember it as ink blot leakage or smokestack leakage. Okay, so again a straight forward question with very nicely put question by the examiner, I would say the answer to this question is cystoid macular edema. Moving on to the next question which was asked there. Now this was a relatively newer question related to a very important topic, that is diabetic retinopathy. But this was I would say one level higher than what they have been always been asking. But if these were the choices what are mentioned here in this slide, again we had a very good clue that what should be the answer. The question was, which of the following is not a criterion for severe NPDR? Now, NPDR means non-proliferative diabetic retinopathy. NPDR means non-proliferative diabetic retinopathy, means there should be no neovascularization. So if there was a choice of neovascularization, that becomes answer to that question, because neovascularization means stage of proliferative diabetic retinopathy. So if that was the choice, then even you do not know the rest of the criteria of severe NPDR, you could have made the question correct if neovascularization was the choice. Otherwise, if the choices were somewhat in a different way, how do we define severe NPDR? There is criteria based upon the ETDRS study. Okay, remember we know the ETDRS study has classified diabetic retinopathy into different stages, and it has also classified non-proliferative diabetic retinopathy into mild, moderate, and severe NPDR. And what are the three criteria one of which should be present for a case to be labeled as severe NPDR. So that is guided by what is known as 4:2:1 rule. 4:2:1 rule. So what is that? That is, either there should be retinal hemorrhages present in all the four quadrants of the retina, or there should be changes in the vein in the form of venous beading in at least two or more quadrants, or the presence of IRMA. I'll just show you what is IRMA. Presence of IRMA in at least one quadrant of the retina. So if that is one of this is there, then we classify it as severe non-proliferative diabetic retinopathy. But if you see new vessels, that becomes proliferative diabetic retinopathy that we all know. So this was a relatively new question put by the examiner as far as the history of Fmge ophthalmology question goes. So to make you understand here, so in this, if we divide the retina into four quadrants here, so you can see the retinal hemorrhages, they are present in all the four quadrants. Okay, all the four quadrants are showing retinal hemorrhages. So that is one criteria of the severe NPDR. Or if there is present venous beading, that the veins, see how the veins are changing their lumen width, you can say. There is beading. Okay, at some places the lumen is more, at some places the lumen is narrower. So that is called as venous beading. So if we see on fundus examination this kind of venous beading in at least two quadrants, so that will be labeled as severe NPDR. Or if we see IRMA. Now what is this IRMA, beta? IRMA is intraretinal microvascular intraretinal microvascular abnormalities. Okay, intraretinal microvascular abnormalities. You can take it as a stage before development of new vessels. Okay, so there is, you can say, see this kind of a loop of the abnormal vessels, but they are within the retina, within the retinal layers. So that is why the name intraretinal. So as a response to ischemia, there is a kind of formation of microvascular abnormal vessels within the layers of retina, which are called as intraretinal microvascular abnormalities, or IRMA. Okay? So this is again a feature of severe NPDR. So this is again a feature of severe NPDR according to the ETDRS classification. Hemorrhages in four quadrants, the venous beating in at least two quadrants, or IRMA in one quadrant. Okay, so these will be the features of severe NPDR. And as I told you, if there is neovascularization, so that will mark as an answer, because that's not a feature of NPDR. Right? Moving on to the next question here. So this was again a relatively new question, but we can expect because they have been asking different instruments in the past. So this time they picked up a forceps and showed the image of that to you and asked you to identify that. So the question was something like, identify the forceps shown in the given image, which is used in cataract, glaucoma surgery, and in corneoscleral repair. So here comes your hint. So it means it is a forceps which is used to hold cornea as well as sclera. So that is why you will use it for the corneoscleral repair. So here is your hint to identify which forceps they are talking about. Okay, so because they have mentioned that this forceps can be used for cataract surgery, for glaucoma surgery, and for corneoscleral repair. This forceps is your corneoscleral forceps, which is a fine toothed forceps. Okay, it has a very fine tooth. If fine tooth teeth, we call it as fine tooth forceps to hold cornea or sclera or even conjunctiva without causing any trauma to the tissue. And this is your limbs forceps. So examiner had shown you the image of limbs forceps, telling you about the surgeries where it is used, and you had to identify that. So limbs forceps or the fine tooth corneoscleral forceps is the answer to this question. This is not a needle holding forceps because needle holders are different. They are more sturdy to hold the needle. Okay? This is not a McPherson forceps. McPherson forceps is like this. It has kind of the prongs there which are not having any teeth, and they are there to hold the capsule or to hold the lens when you are implanting and positioning the lens. The McPherson forceps is also used when we are applying the sutures, when we are tying the sutures. So this is your McPherson forceps. Okay, so this is the McPherson forceps. And the other one which I just showed to you, I'll show you once again. Now this is our McPherson forceps, right? And this is our limbs forceps, which has fine teeth to hold corneal or scleral tissue, right? So that was the answer here, beta. And one of the choice most likely was the superior rectus holding forceps. This again is much sturdier, much bigger forceps uh, with wide tooth teeth to hold the superior rectus muscle. Okay, so superior rectus, the choice D, superior rectus holding forceps is more sturdy, bigger in size, and has wider teeth because that is used to hold superior rectus. So here the right answer to this question is your limbs forceps, beta. Fine. Moving on to the next question here. A child presents with leukocoria and intraocular calcification on ultrasound or CT scan. There is also family history of enucleation. What is the most likely diagnosis? I think all of you must have been very happy to see this question. Again, a very nicely put question with all the keywords in the statement which point towards a very clear diagnosis. So a young child who has leukocoria, means white pupillary reflex, then intraocular calcification, so either mentioned on ultrasound scan or CT scan, family history of enucleation, it means it was some condition which was also present in one of the family members due to which enucleation was done in that person. What is the most likely diagnosis? So a kind of tumor of the child which is causing white pupillary reflex, which presents with intraocular calcification and having the history of same tumor in the family, which must have caused reason for enucleation in that person. So the diagnosis here is towards the most common intraocular tumor of the children or of childhood, which is your retinoblastoma. And I'm very sure that each one of you must have marked this answer right because all the key features are there. It's not retinopathy of prematurity. We know leukocoria can be present in retinopathy of prematurity when it is stage 5, total retinal detachment, but there is no link of family history in retinopathy of prematurity, or you will not see any calcification in that case. It is not pediatric tuberculosis. Tuberculosis can cause uveitis in the eye, but we do not are going to see calcification. Again, no relevance of family history for enucleation. Exudative retinal detachment can be present with choroidal tumors, but again, it will not show up intraocular calcification specifically in a child. So although rest of the choices do not fit into the clinical scenario which has been presented in the question. And as a to refresh your memory of retinoblastoma, this is how the leukocoria will present in retinoblastoma. This is how the tumor will look like, a cauliflower like mass with calcification if it is an endophytic tumor. Okay, and if we do CT, or the calcification can also be picked up even on an X-ray or on an ultrasound. You see how the calcification is seen here. There is a small tumor, but still you can make out there is calcification. So which is very, very specific of retinoblastoma. So very nicely put a nicely put question of retinoblastoma was there for you guys, and I'm sure you have marked that as a right answer. Moving to the next question, again very straightforward, and I'm sure all of you again have marked this one as right. Charetic precipitates are seen in which of the following condition? KPs, charetic precipitate. We have kind of done it as a mantra almost, that we see charetic precipitates. They are feature of anterior uveitis, or which is also called as iridocyclitis. Okay, so that is a feature of iridocyclitis, or another name or another terminology which we use here is anterior uveitis. You will not see KPs in posterior uveitis. Pars planitis can present with snowballs in the vitreous, or you may see snow banking in the pars plana area, but not charetic precipitates. Similarly, posterior capsular opacification has no relation to KPs. There, the appearance is in the form of Elschnig pearls or Sommering ring, but charetic precipitates are hallmark feature of anterior uveitis or iridocyclitis. So we know anterior uveitis has few, typical specific features, which we say there will be presence of anterior chamber cells, or which we call as AC cells or flare and flare. We see charetic precipitates as it is shown in this figure. You may see posterior synecdoche. You may see iris nodules. So all these features are features of anterior uveitis. They are feature of anterior uveitis. Right? Okay, moving on to the next question. Again, I would say very, very good question for all of us. From anti-glaucoma drug, they have put the simplest question to be asked. Which of the following is the first line drug for primary open angle glaucoma? First line drug means, what do we mean by first line drug? The drug which you will be starting as the first drug. In glaucoma, we want to control intraocular pressure. Okay, so to control the intraocular pressure, the drug which is mostly used as a first line drug is your prostaglandin analog, friends. Prostaglandin analogs. We have many drugs in this category. We have latanoprost, we have travoprost, we have bimatoprost. Okay, so all these prostaglandin analogs, they can be used as first drug to be started in a glaucoma patient, in primary open angle glaucoma patient, to control intraocular pressure. Supposedly, the pressure is not controlled by one drug. then we add another drug, then we call it as second line drug. Second line drug means when you add another drug to the first drug so that you can get a better control, because combination therapy can be given in glaucoma where where two or more than two drugs, they act together to control the eye pressure. So that is why the terms first line, second line, third line drugs can be used. So please remember, the first line drugs, unless they are contraindicated, there are very few contraindications of prostaglandin analogs. We do not give these in the presence of inflammation or cystoid macular edema. Otherwise, we can give that safely to rest all the patients. Whereas beta blockers, alpha agonists, or pilocarpine, they are not the first line drugs. They may be combined with the prostaglandin analogs as second line drug or third line drug to control the pressure. Okay, so hope this is clear to all of us. And again, a very good question from a very important topic of anti-glaucoma drugs. Right, so again, the question from a very high yield topic, that is your visual field defects. The question was something like, a patient presents with complete field loss on the right side. What is the site of the lesion? Complete field loss on right side means on one side only. So you know that if the field loss is gone only on one side, it means it's involving only one eye, unilateral, only on one side. Then it has to be a lesion on in the either retina or optic nerve. Okay, because all other parts of visual pathway, whether it is optic chiasma or optic tract or optic radiations or occipital cortex, in all other parts there will be field loss on both the sides, in both right and left eye. So here, what should be the site of lesion? Optic nerve, because it is a monoocular. It is a monoocular field loss. Monoocular field loss. And a quick reminder to the visual field defects, a figure which I always show to you. If it is central scotoma, it's going to be macular lesion on one side. If it is, this is what they were asking. This was the question which they asked, that right side complete loss of field is there. It means the lesion is in the right optic nerve. If it is bitemporal hemianopia, it is your optic chiasma. If it is homonymous hemianopia, the lesion will be in optic tract. Then the quadrantic defect, superior ones, temporal lobe, quadrantic defects, inferior, pie on the floor, parietal lobe lesion, and homonymous hemianopia with macula sparing is seen in the cases of lesions in occipital cortex. Right? So coming back to the question here, complete field loss on the right side indicated that they are asking about monoocular field loss. The answer should be your optic nerve. Right, friends? Moving on to the next question, which most likely something like this was asked. Painful loss of vision can be seen in a lesion involving which of the following? So again, in the choices, they have given different sites in your visual pathway, and they are asking painful loss of the vision. Now, among the choices given of optic tract, optic nerve, optic chiasma, occipital cortex, again, it is the lesion of your optic nerve. Lesions of your optic nerve which can cause loss of vision, which will be painful. For example, optic neuritis. We know the inflammatory lesions of optic nerve, they are presenting with loss of vision along with pain, which is usually worsened by the ocular movements. because optic nerve is inflamed, the sheets around the optic nerves are inflamed, and when eyeball moves, so there will be, because of the inflammatory process, there is sensation of pain there. Okay, so optic neuritis is a condition where you will see painful loss of vision. The lesions of tract, chiasma, or cortex, they are not going to cause pain. Moving to the next question. Again, this was a relatively new question as far as FMG exam is concerned, but a very important one, I would say, and they might ask related question in the future also. Which of the following is the best prophylaxis to prevent endophthalmitis? Okay, endophthalmitis after the surgery. Okay, most likely they are asking after the surgery or to prevent post-operative endophthalmitis, post-op endophthalmitis. The choices given were povidone iodine 5%, preoperative antibiotics, post-operative antibiotics, intravitreal antibiotics. Now, according to the endophthalmitis study, what they found that after the surgery, the most common organisms which cause acute endophthalmitis, they are your commensals. Okay, the bacteria who are already there around the eye, in the on your lids or your eyelashes or your conjunctival sac. So they are the main causative organisms. So we have to provide antiseptic prophylaxis against these commensals so that they do not cause endophthalmitis after any intraocular surgery. And this study also found that antibiotics have no proven role. No proven role. Prophylactic antibiotics, whether you give them pre-operatively, that is before the surgery, or you give them post-operatively, that is after the surgery, they do not have any proven role to prevent endophthalmitis. Okay. Similarly, intravitreal antibiotics, they are used to treat endophthalmitis. To treat endophthalmitis, we do not give them as a prophylaxis. So as prophylaxis, the best and the proven method to prevent post-op endophthalmitis, dear friends, is povidone iodine. We use 10% solution to paint the skin around the eye for the skin prophylaxis, and 5% solution is put in the conjunctival sac to have antisepsis in that area. Okay, so just showing up you this figure because anything visual stays in our mind. That is my theory. So here you see you do a painting. So it is the betadine. Povidone iodine or povidone iodine is your betadine beta. Okay, so the betadine or the povidone iodine, you paint the skin of the eyelid and around the eye area by 10% solution, and then you also put 5% povidone iodine in the conjunctival sac on the eye surface, on the ocular surface, to provide prophylaxis. Okay, so please remember this for your future reference, that how important that thing is, right? Okay guys, moving on to the next question. Fmge test shows breaking up of the colored halos. Which of the following is the likely diagnosis? So this time they have, like, elaborated the question on Fmge test. It has been asked a few years back also, but not on this way. So what are they asking here? That Fmge test is done and that shows breaking up of the colored halos. So we know the three differential diagnoses of colored halos. Okay, so what are those? Primary angle closure glaucoma or acute I wouldn't say primary, the acute angle closure glaucoma, the attack of acute angle closure glaucoma, immature senile cataract, and purulent conjunctivitis or mucopurulent conjunctivitis. So these are the three conditions where we see colored halos. Now, which is the type which will show breaking up of the colored halos? So out of this, that is seen in immature senile cataract. Immature senile cataract. Because Fmge test is a test where we present a stenopic slit to the patient. Okay, so stenopic slit means it has a slit-like area through which the patient will see, and then they will describe whether their colored halos are remaining the same or they are breaking up and rejoining. Now, in angle closure glaucoma, they do not break up. They do not break up. Okay, they stay the same whether the patient is looking through the stenopic slit or not. Whereas in immature senile cataract, when the patient is looking through the stenopic slit, the colored halos they break, and when he's not looking through the slit, they rejoin. Okay, so again, I can show you this figure to have a visual memory of this. So this is how you present a stenopic slit to the patient. So when patient is looking through the stenopic slit, these colored halos, they break. Patient was seeing colored halos all around, then they break in one area. And when the slit passes through, again they rejoin. So this is your Fmge test. So if this is happening, it means the halos are due to immature senile cataract and they are not due to angle closure glaucoma. Okay, so if this was the scenario, then the answer is immature senile cataract. Should be, because this will be happening when Fmge test is performed by a patient who is having immature senile cataract. Okay, we do not see any colored halos in primary open angle glaucoma. They are feature of acute angle closure glaucoma. When the pressure becomes very high, the cornea becomes edematous. That's why the patient sees colored halos. Fine, friends. Moving on to the next question, there was a question based upon the management of cataract in a 3-year-old child. Which of the following is the best management of cataract in 3-year-old child? We know that surgery is the best management of cataract. Okay. Now, which surgery? The choices likely were cataract removal and goniotomy. Now, why would you do goniotomy in a patient who is having cataract? Goniotomy is a surgery for congenital glaucoma. So this choice is ruled out. Okay. Then observation, why would you observe? Because if you keep on observing, this child may develop amblyopia. So again, this is not the answer. Phaco aspiration only means you do the surgery and aspirate the lens, the cataractus lens. Now this is not the best management, because in children, there is very high chance of developing posterior capsular opacification. Okay, so we do the surgery, we do the lens aspiration. We in children, what we do the lens aspiration. If you are doing it with phaco probe, then it is called phaco aspiration. Okay, and then you make a primary posterior capsulotomy. You make an opening in the posterior capsule in the primary surgery itself. Okay, so this is to prevent PCO, because even if the PCO develops, the central area is already having a capsulotomy. So anterior capsulotomy is done in all the cases, the capsulotomy or CCC, curvilinear capsular access. But in children, what additional thing we are doing? We are making an opening in the posterior capsule also, a small opening in the center, which is called primary posterior capsulotomy. That is to prevent the risk of having central PCO. So the right answer for this question, the best management will be phacoaspiration and primary posterior capsulotomy. Okay, so again, a good question and a straightforward question. Right, so this time there were a lot of questions based upon the neuro-ophthalmology. If you see, I think nearly 4 questions or so. And one of this was, which of the following antitubercular medication causes color vision abnormality? Okay, so antitubercular drug, because tuberculosis is so common, a lot of people, they are put on ATT to treat that. So one of these ATT drugs can cause color vision abnormality. Now, why the color vision abnormality or acquired color vision problem will occur? That can occur due to either when there occurs some retina disease, okay, or there is an optic nerve disease. Okay. These are the two reasons for acquired color vision abnormality. Okay, so these drugs, which of the drug you think causes one of these diseases? So if you remember, my dear friends, ethambutol is the ATT drug which causes toxic optic neuropathy. Ethambutol causes toxic optic neuropathy, more commonly one of the very common drugs causing toxic optic neuropathy. So when there is toxic optic neuropathy, as a result of that, the patient will have color vision abnormality, visual field defects, and then it's always better to stop ethambutol if a person develops toxic optic neuropathy. Okay? So the right answer to this question is ethambutol as the answer. Fine. Okay, moving on. So another question based upon, you can say, it was a combined question of, you can say, systemic problem as well as the ocular symptoms in systemic diseases. The question asked was, optic nerve glioma is seen in, and the conditions given were most likely neurofibromatosis, tuberous sclerosis, Sturge-Weber syndrome, Vickett syndrome. Now friends, optic nerve glioma out of these choices is a feature of neurofibromatosis, mostly neurofibromatosis 1. Okay, so we see optic nerve tumor there, and that should be the answer of this question. So in neurofibromatosis, you see, besides the optic nerve glioma, so this is how it looks like. It will produce a fusiform enlargement of the optic nerve, which can be picked on the imaging. So this is your optic nerve glioma. Another thing which you should remember in the ocular features of neurofibromatosis is presence of Lish nodules in the iris. So these are the two features which you will see in neurofibromatosis 1 as far as eye is concerned. Optic nerve glioma and Lish nodules, which are actually hematemus tumors of the iris only, but they appear as nodules, so they are known as Lish nodules. Right? Now, among the other conditions, they can also have some of the ocular features. Vickett syndrome, we know that can cause posterior pan-uveitis rather in the eye. It causes pan-uveitis in the eye. Sturge-Weber syndrome can cause episcleral as well as choroidal hemangiomas. Okay, Sturge-Weber syndrome can cause episcleral or choroidal hemangiomas. Tuberous sclerosis can also cause a tumor of the optic nerve, but it is called as astrocytic hematoma of retina and optic nerve. Okay, so it can cause astrocytic hematoma of retina or optic nerve. So again, it's an important topic actually, and we can see the level of the question asked is, a bit higher in terms of these questions. So to know the ocular manifestations of some of the commonly asked systemic diseases will be good to review. Right? Moving on to the next question here. This question again, a very, I would say, a new question asked in the exam, which is again a combined question of eye and ENT. Which of the following bones are removed in DCR surgery? So we know DCR surgery is done for chronic dacryocystitis. It's dacrocystorhinostomy, where we are making a fistula between the lacrimal sac. So what we are doing is we are making a fistula, that is a communication between lacrimal sac and middle meatus. Now, where is lacrimal sac, my friends? Lacrimal sac is located on the medial wall of the orbit. Okay, lacrimal sac is present in the lacrimal fossa, the medial wall of the orbit. Medial wall of orbit. So if I have to make an opening, I have to create a fistula between the sac and the middle meatus of the nasal cavity, then I have to reach lacrimal sac. And to reach lacrimal sac, I will have to remove the bones which are making the lacrimal fossa. And if we see the anatomy of the medial orbital wall, from front to back, there are 4 bones, starting most anteriorly from frontal process of maxilla, then lacrimal bone, then orbital part of the ethmoid bone, and then body of sphenoid. Okay, another view here. So this is your fossa for the lacrimal sac here, which is formed by the frontal process of the maxillary bone and lacrimal bone. So this is the fossa for the lacrimal sac. So I'll have to break these bones so that I can create a fistula between the lacrimal sac and the middle meatus. So that gives me my answer to this question. The bones which are broken or removed in the DCR surgery, the answer should be maxillary and lacrimal bone. The part of the maxillary bone which is making lacrimal fossa, and of course lacrimal bone. Okay, so that's the right answer to this question. Moving to the next question. Now this was a very tricky question, and this question was based on the clinical scenario. And what was the exact language of that clinical scenario? Of course, we do not know. But the question was something like, a mother brings her child for a second opinion who has been using glasses since the age of 2 years. So child, when he was or she was 2 years of age, was given glasses to correct accommodative esotropia. So we know esotropia means convergent squint. And when it is due to abnormality of accommodation, that is called as accommodative esotropia. On examination, this child is orthoptic with glasses. So when you are seeing this child now, okay, so the child is wearing these glasses and you see there is no squint. It means the child is ortho or orthoptic with the glasses at the moment. Now, what should be the next step in the management of this case? Shall the child be advised convergence exercises or continue with orthoptic glasses which the child is wearing, or to opt for surgery for the squint or discontinue the glasses? Okay. Now, before we answer this question, let me just briefly tell you about accommodative esotropia. Accommodative esotropia usually presents at the age of 2 to 3 years, and it is due to abnormality of accommodation. We know that whenever our eyes they accommodate, that when you want to look at a object which is near, when you accommodate, there is also convergence. The eyes they move inward. If there is abnormality of accommodation, that there is undue convergence in relation to accommodation, that can lead to esotropia, okay, which is known as accommodative esotropia. Now, this is of three types. First one is called refractive, in which the child has a high hypermetropic error. There is a normal AC by A ratio. AC by A ratio means accommodative convergence to accommodation. Okay, this is accommodative convergence, ratio of accommodative convergence to accommodation. So that is called as AC by A ratio. This can be measured. Okay, so if AC by A ratio is normal, but child is having high hypermetropia, and the angle of squint is same for near or distance, then it is refractive type. Okay, then we have a second type which we call as non-refractive, in which refractive error is very minimal, but AC by A ratio is very high. So convergence in relation to accommodation is very high. In those cases, the child has more squint when they are looking at near than at the distance. And then we have a third type, which is a combination of these two. Okay. Now, it's very difficult to tell that whether they qualified or they gave the description of the accommodative esotropia, that whether it is refractive. If it is refractive, then glasses are the treatment. As the child grows, so depending upon starting from 2 years, maybe by next 5 years or 6 years, once the child grows, he or she may not require glasses if the child is having no squint without glasses and accommodation is normal. Okay, but if the child is having squint with the glasses, you have to continue the glasses. Okay, and if the squint is not getting controlled by the glasses also, then you can add exercises or you may go for surgery after certain years. Okay, so it all depends upon that what is the age group of the child which is being examined, or whether it is an accommodative refractive type of the squint or non-refractive, and what is the status of the esotropia without the glasses. So here it's a little tricky question. Going by whatever information is here, if the child is orthoptic with the glasses, but without glasses, the squint is seen, then we will continue with the glasses. And in case the child is like, there is no squint without glasses and there is no significant refractive error now, then we might discontinue the glasses. But if there is squint with glasses also, and the age is, nearly reaching 10 years, then we might go for surgery. So at this point of time, the answer will depend upon whatever information we have, and based upon whatever information is there in this statement, we will continue the orthoptic or the bifocal glasses, which are helping to control the squint. Okay, right? Okay, moving on to the next question. Now then there were few questions based upon the vitamin A deficiency. Again, I think most of you have read it, you know it, and must have marked these questions. They were simple, straightforward, one-liner questions. May have marked this as a correct answer. So one of the question was, which of the following is the most common cause of blindness in children? We know vitamin A deficiency is to be marked as an answer for this question. Most common cause of blindness in children is vitamin A deficiency. Then moving on to the next question, there was probably a question related to deficiency of which of the following vitamin causes night blindness. So again, night blindness is a symptom of xerophthalmia, and we know xerophthalmia is caused by vitamin A deficiency. Depending upon the severity, WHO has given a whole classification of xerophthalmia, which can be starting as a first sign of conjunctival xerosis, bited spots, corneal xerosis, keratomalacia, corneal opacity, and there can be even fundus changes due to vitamin A deficiency. So night blindness is the first symptom of vitamin A deficiency, right? Then there was likely a question on a case scenario of glaucoma. The question was something like a patient presents with red eye, high intraocular pressure, and shallow anterior chamber. Okay, so the pressure is high, the eye is red, but anterior chamber is shallow. There is suspected misdirection of the aqueous fluid. What could be the likely diagnosis? So we know, though it is a very uncommon type of glaucoma, but there is one condition in which aqueous, rather than flowing into the anterior chamber and then draining out, it is misdirected towards the vitreous cavity. Okay, so that is also known as aqueous misdirection syndrome. Aqueous misdirection glaucoma or aqueous misdirection syndrome. Usually it is a rare complication of intraocular surgery, which can be even your cataract surgery or glaucoma surgery, though it's a very rare complication. But because of this aqueous misdirection, the pressure in the vitreous chamber, it pushes the iris diaphragm, the lens iris diaphragm, or the lens IOL diaphragm towards the anterior chamber, and the anterior chamber appears flat because there is no aqueous coming on that side. It's moving on to the posterior part in the vitreous chamber. So this is a condition which is called as also malignant glaucoma. So most likely they wanted you to ask that what is the diagnosis? The diagnosis is malignant glaucoma. Okay? So in this case, because of aqueous misdirection, the aqueous is not able to flow or drain out of the anterior chamber, and there is a high pressure. Okay, answer is malignant glaucoma. So it's not, of course, primary or angle closure or open angle. Neovascular glaucoma is the one which is secondary to the neovascularization of iris and anterior chamber. Here it is aqueous misdirection, which is the reason. Okay? So this was compilation of your ophthalmology recall questions, which were asked in this exam which happened on January 20th. And as you could see, there were a number of questions asked from the ophthalmology. They did stick to the topics which were high yield. There were some newer questions coming into the scene, but there were a lot of questions which were quite straightforward and from the often repeated topics and often revised topics. I wish you, the guys, all of you who have appeared in this exam, a very best result. I'm sure you guys are going to have a great result and achieve the success with flying colors. Thank you very much for being there in this session, and I wish you all the very best. Thank you so much. Take care.